There are people spending serious money on their smile lines who have never been told that the mechanism producing those lines is located 3 feet below their face in a nerve that runs through their hip, and that until that nerve is addressed, every topical intervention they apply is landing on the symptom while the cause continues operating underneath it. I want to be direct about something before we go further into the anatomy. I'm not someone who enjoys telling people their approach has been wrong. That's not why I'm here. But there are situations where the gap between what we know clinically and what gets communicated to the public is large enough that staying quiet about it stops feeling like an option. This is one of those situations. Your smile lines, the nasolabial folds specifically, the lines that run from the sides of your nose down to the corners of your mouth, are structural, not primarily cosmetic. The tissue that forms them is sitting lower than it used to sit. And the question of why it's sitting lower has an answer that has nothing to do with the skin itself and everything to do with the geometry of your body below your waist. Let me show you the deductive chain. And I'll be precise here because the chain only holds if each link holds. The lateral femoral cutaneous nerve exits the lumbar spine, travels through the pelvis, and passes under or through the inguinal ligament at the front of the hip before entering the thigh. It's a sensory nerve primarily. It doesn't control major muscle groups directly, but it passes through a narrow anatomical passage, and at 90-degree hip flexion, the angle your hips form when you sit in a standard chair, that passage narrows. If you sit for hours in that position, the nerve experiences sustained mechanical compression at that passage, not acute compression, cumulative compression, day after day. The body reads nerve compression as a threat signal. It doesn't matter that the threat is your office chair and not an injury. The nervous system's response to that signal is protective guarding in the surrounding musculature. The hip flexors, the psoas and iliacus specifically, increase their baseline tone. Not in a way you can feel consciously, not in a way that shows up as pain, at least not initially. It shows up as a resting shortness. Those muscles stop returning fully to their resting length between sessions of sitting. That's the first link. Compression to guarding to shortened hip flexors. It follows necessarily from the physiology. The second link. The hip flexors are not isolated muscles. Thomas Myers, whose work mapping the myofascial meridians of the body produced some of the most important anatomical thinking of the last 30 years, documented the anterior superficial line in a way that changed how anatomists and clinicians think about body-wide postural patterns. The anterior chain runs continuously. The hip flexors connect to the rectus abdominis through their fascial relationships. The rectus abdominis connects to the rectus sheath. The sheath connects upward to the fascial layer at the sternum. From the sternum, the fascial tension continues through the pectoralis minor, through the anterior neck structures, through the platysma, and into the superficial facial muscles. Dr. Carla Stecco and her team at the University of Padua, whose cadaveric dissection work on fascial continuity is among the most rigorous in the field, demonstrated that these connections are not incidental. They're load-bearing. The fascia transmits mechanical tension along these meridians in the same way a rope transmits tension. If you shorten one end of the rope, the other end moves. The second link, shortened hip flexors, leads to reduced anterior chain length, leads to mechanical tension transmitted upward through the chain to the face. Third link, and this is the one I want you to hold with particular care because it's the most counterintuitive part of the deduction. Facial soft tissue, the fat compartments, the muscle, the skin, is supported from below by the structural length of that anterior chain. When the chain is at full resting length, the tissue sits where it belongs. When the chain is shortened by even a few centimeters of cumulative muscular contraction, the mechanical support for that tissue changes. The tissue doesn't fall suddenly, it drifts. Over months and years of the same compressed hip position, producing the same protective guarding, producing the same shortened chain, the tissue drifts downward. Not because of gravity alone, not because of collagen depletion alone, because the structure that was holding it at a certain height has been progressively shortening. A shorter chain. tissue sitting lower than it used to sit, lines deepening in the face. The geometry of those three facts is not a coincidence. There's a woman I want to tell you about. She's not a patient of mine specifically. She represents a pattern I've seen across many conversations. Her grandmother used cold cream. That was the technology available for the face. Emollients, petroleum-based preparations, the understanding that skin needs moisture. And her grandmother's nasolabial folds deepened anyway, as they do, because nobody in that era was thinking about the anterior chain, and nobody had the language to explain what was happening structurally. Her mother had access to retinoids, to peptide creams, to the early understanding of collagen synthesis. Her mother spent carefully on her face and achieved some real results in skin quality, texture, tone, fine lines near the surface. But the deeper fold, the nasolabial fold specifically, kept deepening. She thought it was simply her genetics expressing themselves. Her mother before her had them. She had them. This is just how the face ages in this family. She watched her mother do all the right things at the face level and watched the result that the face level interventions couldn't touch. When she came across the LFCN argument, the anterior chain argument, her first response was skepticism. That's the correct first response. The claim is large and the mechanism is not intuitive. But she worked through the chain herself. She traced the anatomy. She asked, is there continuity between the hip flexors and the facial muscles? The answer anatomically is yes. Is the lateral femoral cutaneous nerve genuinely vulnerable to compression at the inguinal ligament? The answer clinically is yes. This is a documented condition called neuralgia paresthetica in its pathological form. And subclinical compression at this site is recognized in the neurology literature as common in people with extensive sitting history. Does sustained nerve compression produce increased baseline muscular tone in the surrounding area? Yes. Does increased hip flexor tone shorten the anterior chain? Yes. Each link she checked, each link held. So she ran an experiment. Not a cosmetic experiment, a structural one. Let me take you through what she did, because the protocol matters, and it needs to be specific enough that you can replicate it. She found a space on her floor each morning, not a yoga mat, just the floor. She lay on her back, not with her knees pulled to her chest, which is a common but incorrect starting position for this work. She started with her knees bent, feet flat, and then extended one leg fully along the floor. The goal of that position is to allow the hip flexor complex on the extended side to release into length without active effort on her part. She let gravity do the decompression. The lumbar spine in this position will often flatten against the floor on its own as the psoas releases. That's the observable marker she was looking for. Not pain relief, not a sensation of stretch, the floor contact at the lumbar spine. She held that position initially for 3 minutes per side. Not because 3 minutes is the correct number. She didn't know the correct number. She held it until she felt the hip flexor tissue change quality, from resistant to something she described as available. That took approximately 3 minutes on the first day. By the fourth day, it took less. By the end of the first week, the release happened within 90 seconds. During the second week, she added an anterior chain extension. From the same supine position, once the hip flexors had released, she moved into a gentle thoracic extension over a rolled towel placed at mid-back level. Not a stretch of the lumbar spine, mid-back. The goal was to restore length to the rectus sheath and the fascial structures connecting the abdomen to the thorax. She tracked 3 things over 14 days. Her resting posture at the neck, specifically whether her chin position was lower than it had been, which is a reliable indicator of anterior chain shortening, the ease with which she could stand fully upright without feeling a pull at the front of her hips, and the nasolabial folds themselves, photographed in the same lighting, same distance, same neutral expression. What she found on days 4 through 7 was the neck position change. Her chin rested slightly higher at neutral. That was the earliest visible indicator that the chain was responding to the decompression work. By day 14, the photographic comparison was not dramatic. She hadn't expected dramatic. She'd expected directional, and that's what she found. The depth of the nasolabial fold on the left side, her dominant sitting side, the side she crossed her legs toward, had changed measurably. Not erased, changed in depth and in the way the tissue distributed around it. She kept going. Week 3, 4, 5. The change continued to be directional. She hasn't changed her skincare routine. She added nothing to her face. She addressed the structure below her face. There's a question I haven't answered in this video, and I want to name it specifically because it's the question that should be living in your mind when you finish here. It's this. When the anterior chain has been shortened for a decade or 2 or 3, when the hip flexors have spent that long in an adapted, shortened state, how much of that adaptation is reversible, and on what timeline? The 14-day experiment gives you the early data. It tells you the chain responds to decompression. It doesn't tell you the full recovery curve. Nobody has mapped that curve in any rigorous study I'm aware of, and the absence of that data is something worth sitting with. What we know is the direction. What we don't yet know is the distance. That's an investigation I find genuinely important, and it's one I'm not ready to close. Now, the 3 women I described earlier, grandmother with cold cream, mother with retinoids, and you with this argument. Decades of information between the first and the third. Not because the anatomy changed. The anatomy has been the anatomy the whole time. Because the right people weren't asking the right questions across the right specialties. Your children and your children's children will either have this information or they won't. They'll spend the same money their grandmother spent on the same surface, or they'll understand that the surface is downstream of something structural and start there. That difference between treating the face and understanding the face as the downstream consequence of a hip geometry is information that changes what gets passed forward in a family. The cosmetic industry isn't going to tell you this, not because of malice, because the industry is organized around the site of the symptom, and the site of the symptom is where the products are. You already knew something was incomplete about the standard explanation. The fact that the creams worked on surface texture but not on the fold itself, that was information. The fact that the deeper lines didn't respond to the things that helped the surface, that was information. It was pointing to a structural problem the whole time. And the word for the geometry that produces it finally has a specific address now. That address is in your hip. More precisely, it's at the inguinal ligament, where a nerve has been compressed by a position you've been living in, quietly shortening the chain that was holding your face where your face belongs. Begin the experiment. 14 days, the floor, the morning, the extended leg. Track what you actually observe, not what you hope to observe. The deductive chain tells you what should happen. Your body will tell you whether it does. If what I've explained here is tracking for you, if the anatomy makes sense, if the logic holds when you check each link, consider staying close to this channel. The depth of this work goes further than one video can reach, and there's more anatomy worth understanding the same way. Not as a cosmetic problem, but as a structural one with a structural address. What that looks like when the chain has been shortened for 3 decades rather than 1 is a different conversation, and one I'm working toward.